Yeah, that's correct. Can you see my screen?
Yes, we can.
Yeah, that's good. So these are my disclosures. I'm going to combine in this talk two things you put together, and they actually fit quite well with Dr. Kracher's talk about aneurysms with no neck and how that's been approached. The sac sealing concept was one that he showed at the end with the Nelix device. And what that does is with two stents, as I'll show you, going along the entire length of that aorta, to be able to then expand two Teflon bags that fill up the aneurysm sac itself. And the concept being that if you fill that aneurysm sac uh, with material, that stops the type 2 endoleaks and gives you an opportunity to rely on the aneurysm sac itself to hold the device in place. This is some early work, and I wanted to run through it just to give you the concept that were done in sheep in order to evaluate this device. So this is an ovine aneurysm model where when you place one of these stents and then the Teflon bag around it, what you end up with is the stent, the thrombosis around the device, and the ability to exclude that aneurysm. Now, the one problem that will become apparent later from this animal model is that we don't have, as Dr. Kreischer's alluded to, over time changes in the aortic anatomy that enlarges. And so this is how this device works. There are two catheters that are introduced that have the sealing stents in the middle. That's the primary flow lumen when it's expanded. And with this placed directly below the renal arteries, what you get is these flow lumen established, and then with expansion of the balloon and keeping that up for a period of time, it lets that material that's been injected seal the aneurysm. So this is an angiographic view of what that looks like, placing the device, expanding those flow lumen devices, then the sealing bag, which has the material in there that holds the seal in place. And, this is an ideal final angiogram of what that looks like. There was a series done early. This is an example of that. The aneurysm, the sac itself with the device in place. And then over time, and if you look at these serial images, the aneurysm before, and then out to 36 months, you see the expanded Teflon bags, the aneurysm excluded, and this is an ideal case. Now, the other advantage of this has been that the type 2 endoleaks, which you get with a conventional graft, by having that aneurysm sealing bag in place, you're able to eliminate that. So that's been one of the things that's made this an appealing device. There was a large clinical study done in the United States with about 90% of the patients having success, but I wanted to emphasize what are the failure mechanisms here because this goes again along with Dr. Kracher's point of the complex anatomy near the renals. And where that device failed in the clinical trial was either low placement, so that this segment here was not protected and you could get a type 1 endoleak, as is demonstrated there. Or on the other end, if the iliacs dilate, and we know they do that, then you can end up with a distal endoleak as demonstrated in this. So the challenges then that were recognized are to be able to overcome that. And what's occurred with analysis of that data is that they've now made a recommendation to not use that, or to be able to have a 10 millimeter proximal neck, and the same in the hypogastrics in order to prevent those type 2 leaks. One of the other options to bail this out, and this relates again to what Dr. Kreitzer showed you, is that in devices that have lost that proximal seal, to add a segment here with either parallel grafts or snorkels in order to secure that. So this really ties up with what Dr. Kracher showed you in two of the technologies that are evolving with that sac sealing, which is going to be demonstrated in the future. You also mentioned the multi-flow layer, and what I'll do here is try to introduce what Amira is going to show you, I think, in a moment about long-term follow-ups. But when you talk about multi-flow layer devices, there have been several variations on these porous expanding grafts, as I'll show you. There's no real standardized way to characterize these. So if you're going to tell somebody exactly what it is, it's hard to without that standardization. And the theoretical advantages are, as I'll show you now, there are on the market a number of these these MFM devices that are used in the cerebral circulation. This is a list of them here, including the cardiatis device that I'll focus on the bottom. And in the cerebral circulation, these have been very successful to seal aneurysms with regression over time. There may be a difference in those cerebral aneurysms compared to the infrarenal. This is the device configuration, and this is 2 layers of stents that are woven in a very specific pattern that give you an advantage, very much like this analogous to when you have a water tap in the upper left-hand corner. If you put a restrainer across that reduces the porosity at about 50 to 60%, you change that flow from very turbulent to laminate flow. And that's the basic concept of the multi-flow layer stent, where here in a prototypic aneurysm in a flow pattern, you have turbulence. When you put the multi-flow layer in there, you laminate the flow, with the consequences being, as I'll show you, lamination of the flow and then creates thrombosis. In the experimental animal work that was done, what we were able to show, in this case, a histologic slide, where with those 2 layers, one heals and the other gives you a laminated surface that then endothelializes. And these were, in the animal models, very rapidly incorporated. The other important finding, which kind of relates to the last question you asked Dr. Kracher, is if you put these across side branches, they remain patent, which is a finding that's hard to really focus on conceptually. These are what these look like from the animal results, and you can see that double layer in the endothelialization. And that actually has corresponded to findings in a patient. This is the case that I was actually at with Dr. Kostasi in Romania, where they had placed a multi-flow layer device previously and then had to come back to replace the aortic valve. And they removed a small segment of one of these devices. Here it is, that had been placed 3 months earlier. This ragged edge is where it was cut, but this is out of the aortic wall. And when you look at it, it actually does, as the animal get an endothelialized layer that is conceptually translates well to what we saw in the animal models. Now, to get at what Dr. Kracher alluded to, and Amira may be able to expand on this some more, these devices have been used worldwide with some adverse reports, but in most of them, they've been used in patients that are outside the IFUs. So the IFU in these are not to use them in ruptures because it doesn't stop the bleeding immediately. Infection, you put that device in, it isn't going to work. And the other part related to the question related to aneurysms, and this is where the controversy has been, the IFU says don't use it in an aneurysm larger than 6 centimeters. In an aneurysm, and these are the flow models from patients now, what you see is here the turbulent flow before you place the device, and afterwards how it laminates here, and then you get the thrombus that I'll show you in a moment. This is an example then of a patient with this saccular aneurysm in this perivisceral area. After 3 months, the thrombosed area here, or the flow area here, is decreased. And when you look at this again in another patient, the same sort of thing, how here the flow, this is the thrombus. in the aneurysms, and this reporting has now been the controversial part, because in many of these patients with aneurysms, although you do get thrombosis and depressurization theoretically of the aneurysm sac, you don't lose the volume of the aneurysm. So the utility of these in the aneurysm models are yet to be established. One of the things that was found, though, is that when you cross, just like that question to Dr. Kreischer, the visceral vessels, the flow is maintained. All of these branches remain patent, and because of the laminar flow, you actually get an increased flow to the vessels. So this is a 23% increase in flow in a renal artery. This prototypically shows you in an arch aneurysm the flow, how you have it turbulent prior to, and then after placing the MFF across the devices, how this changes the pattern and what lets you be able to have the thrombosis in the lumen. And again, when you look at these and then model them afterwards for what happens with the flow, even in here, all of the arch vessels being crossed on the top, the flow is actually increased to those cerebral vessels. And again, in the studies that have been shown, and Amir will give you some more data, they remain patent. And there's been several studies, and I won't highlight these, but a lot of patients looked at. This is one that Amira had published, and I'm sure she'll expand on that. Now, the useful part of this in dissections is here. This is a visceral segment in a case where I was present and saw this. And once you place the device, you still see flow through those vessels. And this is an example. You put it in. This is very unconventional because you're used to not crossing those vessels. But here you see with the pigtail in place, once you place that device that the video will play, here's the aneurysm sac filling and all the branches still fill. These are examples of here an arch aneurysm treated with the MFM that goes again from the arch down through the visceral vessels. And you can see at 17 days thrombosis or near complete thrombosis of that false lumen. Here another example, again, almost near thrombosis at 17 days. There is some persistent flow up here. And in this particular patient, where it was a young lady who had paraplegia, you can see the length of this dissection. It was covered from the subclavian all the way down to the hypogastrics. This is at 11 days, and this is a patient that was published, if you look back at the Journal of Vascular Surgery in June of 2016, it was the cover. And this patient at 2 years interviewed by Dr. Dietrich, where when you look here at along the device, there's been regression of that dissection and persistent flow even into the vertebral and lumbar arteries. So this is, it relates to what you'll see later where there's no paraplegia in these patients that has been reported. Another example here covering even further down, this patient's been debranched. So this is the device all the way down through. And the important part with the Cardiatis device is not to stop like we do now at the visceral vessels with other devices, but continue the entire length of the dissection so that you get the ability to have those remodel. This is another case, ascending aneurysm, covered the entire length. And if you look at this, all of these at 1 month, the branches to the head, the viscerals, and all of these other branch vessels remain patent. This is a case that Dr. Dietrich actually did where he wanted to treat this ascending aneurysm. And when they placed the device, they actually covered a coronary artery inadvertently. And what they found afterwards is that the flow increased in that. There's a YouTube video of Dr. Dietrich interviewing this patient at 5 years and still had persistent flow. This is that 5-year follow-up. The other thing is with this device, and this has been recommended with other procedures like putting in a branch vessel or fenestrated device, if there's a narrowing in that vessel to pre-dilate it, the same recommendation is with cardiatis, but if in fact you don't get that or you get a recurrent stenosis, you can come back and cross the MFM devices and cannulate those vessels and then dilate them later. So there is an ability not only to maintain flow, but to be able to come back and do that again. This is the current device that has flares on the end, which makes it more suitable for the overlaps. And the bottom line is this is a very disruptive technology. It's hard to imagine you can cover the entire length of the aorta, get something like a dissection to regress and still have those vessels remain. And again, Amir will show you some more of that. So what do we know about the MF devices now? In the intracerebral circulation, these are uniformly used and work well. It may be the cerebral aneurysm is different than others. In other vessels, like the aneurysms, again, there's controversy, particularly because of the size remaining. So that yet has to be worked out, and that aneurysm part of it is yet coming. But the other is the treatment of dissections is a very promising area that I think Amir will show you. And the other thing is keep in mind the contraindications. Don't use it in anything ruptures. You've got to cover the entire length of what you're treating, different to what we do currently. And with that, I'll stop. Thank you.
So that was a great talk, Dr. White. It is wonderful as usual, and it is an 4TS session and also an ISVS collaboration with APVIC. I think we'll have Amira to speak after you so that we can have the whole thing in right perspective, and then we can take the questions maybe after Dr. Vijayvarya's talk.
No, that'd be great. She's got the long-term data. So
yes. So can I request and invite Dr. Amira from Morocco to come and speak about the MFM, long-term follow-up of aortic aneurysms and type B dissections treated by multi-layer flow modulator. Yeah, Dr. Martin has a question in the meantime to Dr. Kreiser. Dr. Martin, can you go ahead with your question, please?
I want to say hello to everyone. Thank you for invitation, Dr. Omar, Dr. Khanna. I'm so happy to see you all doing well. We've just heard,
thank you.
We just heard two giants of aortic interventions giving comprehensive lecture about the devices. I'm sure Professor will just complete it. I have been just using for the short and angulated neck recently the endo anchors by Medtronic, which is device of a small screw advised to be used for the short and angulated necks. But to be very honest, I'm quite skeptical still, because I just, I cannot believe that these small screws can really hold the flow and the pressure which is bumping into the stent graft. Even so, I managed to fix one small type 1 endoleak by using 6 endo anchors, and it disappeared immediately. I would like to ask the panelists if they have a experience with the device as well.
Dr. Kreiser, would you like to take that question?
I'll be glad to do it. So I think I have pretty extensive experience with the use of endo anchors. Actually, I have several publications related to it, and if you Google my name, you'll be able to find those publications. I think they work in a lot of scenarios, but they are not a panacea and total cure for all the complex anatomy. One exclusion for endo anchors would be severe thrombus in the neck. That's totally outside of the IFUs. And the other one would be severe calcification. So I would definitely not use it in those two scenarios. And that would exclude a lot of patients that I presented with challenging infrarenal anatomy. But otherwise, they're very useful in certain subsets of patients with short neck and angulated neck or funnel-shaped neck without thrombus and without calcium.
Zvonko, what kind of complications have you noticed? Like they embolized, or they didn't stay on place? Or tell us, because your experience is perhaps the
right. So they can embolize. Fortunately, we have not had any problems with it because we would not use it in severe calcification or thrombus. but we reviewed with one of our former fellows, so-called MAUD registry of all the complications related to endoanchors. And there was a significant number of those that embolized. So you have outside of IFU. So you have to avoid them when you have a contraindications for the use of endoanchors. Thrombus and calcium are contraindications.
And perhaps the technique of implantation is important as well. You have to be 100% sure you are perpendicular to the lumen, and then you can go ahead. I guess we can go ahead for next presentation, so we can put it all together.
Thank you.